Hi, I'm attorney Casey Walker. I'm the founder of VA Disability Group, and I'm a former VA adjudicator. Today, the purpose of this discussion is to talk about recent changes to VA laws. In addition to the changes, we're also going to discuss proposed changes. So we're going to start with the actually enacted changes that the VA implemented this year that a lot of people still aren't familiar with. And then we're going to segue to the proposed changes that appear to be imminent. I believe that they'll be effectuated or implemented by the end of the year. So without further ado, let's jump right into it. So some of the primary changes with GERD that we're going to discuss is previously under the VA rating criteria, the VA rated GERD under an analogous rating, which was diagnostic code 7346 hiatal hernia. They didn't have a rating code for acid reflux or gastroesophageal reflux disease, which is commonly referred to as GERD. And so what happened is a lot of veterans were claiming disability compensation for GERD. So the VA said, well, we need to create a diagnostic code for this. It's so commonly claimed by veterans. And so they created diagnostic code 7206 just this year, hot off the press. And the criteria to receive compensable evaluations under the new rating criteria, it's very different. Instead of focusing on the symptoms, they're really honing in on esophageal stricture. And you'll notice that every single evaluation that they have, esophageal stricture is referenced. What is esophageal stricture? It's narrowing of the esophagus. So that's what connects the throat and the stomach. So narrowing. Now you'll notice when you go to diagnostic code 7206 that they actually go one step further and say, this has to be documented by some type of objective testing, a barium swallow, a CT, or some type of other objective modality testing demonstrating that you actually have a narrowing of the esophagus. Now, another thing to notice, it doesn't have to be a permanent narrowing. The rating criteria gets into two different terms, recurrent and refractory. So they actually define these terms in the notes. And I'm going to read directly from their definition. Note 4 under diagnostic code 7206 states expressly, recurrent esophageal stricture is defined as the inability to maintain target esophageal diameter beyond 4 weeks after the target diameter has been achieved. So that would be recurrent. And then refractory, which is, we see that term used in the 30%, 50%, and 80% language. Refractory is defined in note 5, which states refractory esophageal stricture is defined as the inability to achieve target esophageal diameter despite receiving no fewer than 5 dilation sessions performed at 2-week intervals. So what we have here with the new rating criteria is a narrowing of criteria and very specific and objective. So what most attorneys and adjudicators foresee is that there will be less compensable evaluations given for acid reflux. So that's bad news. But some of the good news is that previously the VA would only compensate acid reflux or irritable bowel syndrome. They might award service connection for both, but they would only give compensation for one because of anti-pyramiding laws. Under the new criteria, and we're going to jump into irritable bowel syndrome here in a second, but under the new criteria, the symptoms that are discussed in the rating criteria are so different, the VA has determined that you can now receive separate compensable evaluations for both acid reflux and for irritable bowel syndrome. So despite GERD having a narrowed focus and likely will lead to reduced or minimal evaluations, as you'll see in a second here, irritable bowel syndrome has been expanded and will likely lead to enhanced evaluations. So let's talk about irritable bowel syndrome. So the VA has adjusted their irritable bowel syndrome rating criteria as seen and demonstrated in 38 CFR Part 4, diagnostic code 7319. So this is a new diagnostic code with new rating criteria. And what we'll see is that irritable bowel syndrome has really expanded the subjective approach. And what I mean by the subjective approach are sometimes symptoms aren't objectively demonstrable, meaning you can't test for them, meaning you might have these symptoms, but they're hard for another individual to actually see or to witness. So what irritable bowel syndrome does is they focus on abdominal pain, and that's a recurring theme, abdominal pain associated with defecation. So when you go to the bathroom and you have to take a crap, if you're having pain, that's step 1. And then they need to have 2 or more of the following symptoms: stool frequency change, stool form change, straining or urgency, mucosa, abdominal bloating, and subjective distension. So let's parse that out a little bit. Stool form change, yeah, that's pretty common with anyone with irritable bowel syndrome. Stool frequency change is also quite common in someone with irritable bowel syndrome. Straining or urgency, yet again, another common thing that we see almost across the board with our clients. And abdominal bloating and distension. So all of these things are quite common. You only need two, the mucosa, the mucoria. That's one that's not as common, but the other 5 are very common. It's quite normal that every one of those would apply. So for a 10% evaluation, you need to have 1 abdominal pain episode per month, plus 2 of those other things. For a 20%, you need to have abdominal pain with defecation, plus 2 or more of those things 2 to 6 times a month. And for a 30% evaluation, you need to have 1 per week. Most people are going to fall in the 30% range from my experience. We've handled thousands of irritable bowel syndrome cases, and you see this. You see these symptoms over and over again, and they're usually a few times a week. So what we foresee happening is that most veterans, as long as the examiner plays fair and checks the correct boxes when they're doing their examination report, we foresee most veterans getting a 30% evaluation for irritable bowel syndrome. Now, some unique considerations here is that previously when the VA had their irritable colon syndrome, which they rated IBS under, they didn't have a 20% criteria. So they've added a 20% criteria, and that's great. Most veterans got about a 10% evaluation. That would be the norm. I foresee most veterans getting a 30%, but you have a 10, 20, and 30% now. So that's new. The IBS rating criteria is simply more favorable. So that's great news. Again, you can double dip. We can receive compensable evaluations for GERD now and for IBS, and that also that's great for veterans' overall compensable evaluations. And lastly, you're guaranteed a 10%. So under the rating criteria for IBS, there isn't a 0%. You're guaranteed a 10%. So across the board, IBS has likely changed for the better for veterans. One other change that's happened this year actually went into effect January 11th of 2024. It's kind of a nuanced policy change, but it'll likely lead to a dramatic reduction in headache for the VA and for active duty service members who are in the National Guard or Reserves. So what I'm getting at here is when you have your reservists and guardsmen who do their active drilling, or maybe they're activated for a 1 or 2 month period, the VA is required to withhold VA disability compensation payments during that time. The problem is they would always find out about this after the fact. The veteran, even if they reported it, the VA usually failed to have some type of measure in place to stop the payment. And so then you'd have a debt that would be created. It would freak veterans out. It would lead to an increase in phone calls to the help center. It was just a disaster, and it's been this way for decades. Well, this year the VA said that they have the right just to stop the payments. Now, while that sounds bad on paper, I actually think it's going to be a good thing. Because you'll avoid unwanted adjudicator scrutiny. What usually happens is they propose to create a debt, and then you have an adjudicator looking at your file, and you don't want adjudicators looking at your file. You don't want someone seeing that you have 70% for mental health or that they failed to schedule a future exam. So this will take the adjudicator eyes off of your file, and that's a good thing. Additionally, they had a lot of unnecessary costs that were going into recouping the monies that were paid to veterans while they were serving on active duty for their drills. It also confused the veteran, and it'll save veterans time from having to call the help center and trying to explore why they owe the VA money. So the VA will now, they have a matching with the Department of Defense, and they'll know when you're activated, and they'll just stop your payment, and then they'll start it back up the minute your activation's ended. So I foresee this being a good thing. We'll have to wait and see, but I think they'll probably get this right. It appears thus far, we're 9 months into it, that it's going pretty smoothly. So that's one of the other policy changes that we're seeing. And again, it happens with guardsmen and reservists. So next I want to segue to proposed changes. So bear in mind, these have not been implemented. It's very possible these don't get implemented. However, my spidey senses tell me that these will be implemented, and I think they'll actually be effectuated in the near future by the end of 2024. The 2 rating criteria that are likely to change is going to be sleep apnea and mental health. So let's jump right into it. Again, these haven't been changed yet, but let's discuss these two. So starting with sleep apnea, what the VA is proposing to do is reduce the automatic 50% if you have a continuous positive airway pressure machine assigned to you, which is a CPAP machine. I foresee this really hurting veterans. So the standard care is to prescribe a CPAP machine. It's really the primary way that you treat sleep apnea at the moment. So if you get a diagnosis of obstructive sleep apnea, no matter how severe or minor it is, they're going to give you a CPAP machine. This usually resulted in an automatic 50% under the current criteria. Under the new criteria, what they're doing is they're starting to look into whether you have mild, moderate, or severe sleep apnea and how the treatment mitigates those symptoms. And so it's not a sweeping 50% like it used to be. Specifically, they're looking at giving a 0% for sleep apnea that's asymptomatic or without treatment. 10% for incomplete relief with treatment. So what is it? Again, what's treatment? It's a CPAP machine. So they're proposing to give you 10% if you use a CPAP machine, but you're not fully restored to feeling good during the day and getting a good night's sleep. They're also proposing to give a 50% for ineffective treatment or inability to use treatment. And lastly, they're going to propose to give 100% for severe sleep apnea with end organ damage. So the two things I want to focus on here, the 10% for incomplete relief with treatment, that's probably what they're going to try to default to. That you use the CPAP, but you still have some type of symptoms, because it doesn't result in a perfect mitigation of your symptoms. And you got an octopus sitting on your face while you're trying to sleep. Who can sleep with an octopus on your face? That's what my question would be to all these adjudicators. Who sleeps with an octopus on their face? So what I foresee happening is you have a lot of veterans who are going to say, I can't effectively use the CPAP machine because I have PTSD. I wake up, it freaks me out because I feel like I'm being suffocated, or because I can't lay on my stomach because I got this machine on my face. And so I foresee a lot of veterans being awarded an initial 10%, but pursuing the 50% by trying to prove to adjudicators and judges they cannot achieve effective treatment, and that they have an inability to use that treatment, which again is a CPAP machine. Now, one other consideration is there are new treatments that are either in the works or are already here. One's called the Inspire implant. So where they implant something that actually stimulates a nerve muscle and it opens the airway every time you breathe. It triggers that stimulation of the nerve, of the tongue, and it opens up the airway. So that's actually been an active procedure that a lot of veterans with sleep apnea have been receiving for the last decade. And it's not considered by the VA rating criteria, which is interesting. Another one is there's some medications, which is strange, but there's actually pill form medications that are reducing apneic events dramatically. They're still in the initial testing phase, but assuming that one's also awarded, it makes sense that they wouldn't want the only evaluation criteria to be based on a CPAP machine, because there's new modalities and different ways for you to treat sleep apnea. So the takeaway here is it's likely going to be a worse result for veterans. Instead of that automatic 50%, what we foresee is an automatic 10% if you're prescribed a CPAP machine, and then you're going to have to fight for that 50% saying that you can't effectively treat your symptoms. What we recommend is do not file for an increase for sleep apnea. If you're getting 50%, you're already receiving the maximum allowed. Well, technically it goes up from 50%, but I've never seen it awarded. Don't stir the pot if you're receiving a 50%, because you don't want to be reassessed under the new criteria. And the other thing to consider, again, is this is just a proposal right now, so we'll have to wait and see what happens with this. So the elephant in the room, one of the proposed changes is mental health. This is what we really want to talk about here today. We're getting a lot of phone calls from veterans saying that they have anxiety, they're worried about these proposed changes, and I want to just say up front, we foresee these changes leading to favorable results, actually improvements on disability compensation evaluations for veterans. What the VA is considering doing is creating 5 domains, and a domain really just means categories. The categories or domains are going to be cognition. Number 2 is going to be interpersonal interactions and relationships. Number 3 is task completion and life activities. Number 4 is navigating environments, and number 5 is self-care. So those are the domains. That's the exact term the VA's ascribed to these categories, or domains. Now what they're going to do is they're going to take each one of those domains, and the psychologists or psychiatrists are going to have to assess the level of functioning within each domain. And then they have to give you a score, a 0, 1, 2, 3, or 4. 0 meaning no symptoms, 4 meaning total. So we're going to go from 0 to 1 to 2 to 3 to 4, which is no symptoms, mild symptoms, moderate symptoms, severe symptoms, or total impairment. Okay? A level of functioning will be assessed within each domain. Now what they're going to do is they're going to put their number 1, 2, 3, or 4 next to those domains, and then the adjudicator is going to take their report, their examination, compensation, and pension report, the C&P report. They're going to take and they're going to look, this is how it's going to work. They're going to go straight to this part of the exam, and they're going to look for the numbers assigned, which translate to the evaluation. So what's the evaluation? Well, the VA is prepared to award a 10%, 30%, 50%, 70%, or 100%, depending on where you fall with the assessment within the domains. As a starting point, this is a favorable change. You start at 10%. There is no longer a 0% for mental health. So to the extent veterans have received 0% for their mental health diagnosis and service connection in the past, they should immediately file for an increase, because at a minimum, it'll go up to 10%. You should file for it anyhow, because it's rare that mental health conditions and diagnosis are asymptomatic. But 10% starting point, and then what happens is if you have 2 or more domains with a level of functioning assessed as a 1, which is mild, that's an automatic 30%. So 2 or more domains with a mild assessment, a number 1 assessment, that's an automatic 30%. If you have 1 domain with a 2 assigned, which is for moderate impairment, then that'll be a 50%. If you have 1 domain with a 3 or 2 or more domains with a 2, which means you have 1 with severe impairment or 2 or more domains with moderate impairment, that will be a 70%, which is quite difficult to obtain under the current criteria. And then lastly, for the 100% criteria, if you have 1 domain with a 4, which means total impairment, or you have 2 or more domains with a 3, which means severe, that will be 100% disability compensation evaluation. So let's compare and contrast that to the current criteria that's currently existent. In order to receive 100% evaluation of the current criteria, you need total occupational and social impairment. Now you'll notice these domains and these assessments in the level of functioning don't get to the occupational and social impairment. They kind of include it, but it's not a sweeping, you either have total occupational impairment or you don't. Under the current law, you have to have total occupational and social impairment. So you need an examiner who checks a box saying you can't even work 5 minutes in a day. So it's hard to get 100% for mental health under the current criteria. Under the proposed criteria, it becomes significantly easier. One other consideration here is competency. Under the current criteria, if you have 100% disability compensation awarded to you, it really does raise some questions as to whether you have competency issues. Are you incompetent? Under the new criteria, just because you get 100%, it doesn't really suggest that you're incompetent. It doesn't mean the VA won't do competency assessments, but I foresee these becoming less frequent, which is a good thing, which means veterans will be able to handle their finances and not have a fiduciary appointed over them. So we do foresee competency determinations being reduced with this new criteria as well. So that's the changes. I expect these changes to be implemented by the end of the year. Keep in mind, these might not be implemented at all. We might just be status quo with the current criteria for years to come, but most experts in this field anticipate this change will be effectuated. So how does this affect you? Let's assume that these changes are actually implemented. If you're a veteran with a 0, 10, 30, or 50% evaluation, and you're even seeking a nominal degree of treatment, you should highly consider filing for an increase because the new criteria is more favorable. If you haven't been treated, the reality is these examiners want to see that you've been treated. And if you've been treated, they're more likely to check favorable boxes. This just makes sense because you're seeking treatment for a problem. So if you have just an average evaluation assigned for mental health, 0, 10, 30, or 50%, I would encourage you to seek treatment if you haven't been doing that. And if you have been doing that, once you've sought treatment for just a few months, file for an increase. And my hunch is that most veterans are going to get an increase. If you're at 70% or 100% already, you might want to scrutinize things a little bit more. If you're not working because of mental health, you absolutely should be filing for an increase for mental health. Keep your eyes open for these changes. We're going to try to stay on top of notifying veterans through our YouTube channel and other platforms that the changes have been implemented, but as of right now, it's just a proposal. So in closing, let's talk about the things that are unique and the things you want to consider. Be careful filing for increases on some of the conditions we discussed today that are going to be a change for the worse. So your sleep apnea is specifically one of them, and the acid reflux, or the gastroesophageal reflux disorder, or commonly referred to as GERD. Both of those appear to be less favorable to veterans. So if you have a good evaluation for those, don't pursue increases. Don't raise scrutiny to those issues. File an intent to file right now. If you think you want to file for sleep apnea or mental health, or you want to file for an increase, if you want to file for these things, file the intent to file right now, because, for example, the sleep apnea, if your intent to file is filed before the law changes, you'll avail yourself to the previous legal criteria for sleep apnea and for GERD. So getting an intent to file before those laws are implemented could really help you. Now, you only have 1 year to file a claim, so you're really just hedging your bet and protecting yourself for a year. So for example, if you file the intent to file on day 1, and on day 10 the law changes and it's less favorable, and on day 20 you file a claim, in theory, and then under the law, the criteria you're assessed on should be either or, whichever is more favorable. So you'll want to have an intent to file to the extent you're considering filing for sleep apnea or acid reflux specifically. Another consideration, as previously mentioned, is under irritable bowel syndrome and GERD, you can double dip. You can receive compensable evaluations for both. The anti-pyramiding laws no longer apply because the symptoms that are being compensated are so different. Lastly, for mental health, they're looking at these domains, and it should be easier to obtain higher compensable evaluations. I hope you found this helpful. The purpose of today's discussion was to discuss all of the changes that have been underway or are going to be underway in the near future. It's good to keep your head on a swivel for these things because they can lead to dramatic changes in your evaluations. I hope you liked the video. If you did, like and subscribe to the channel. Thanks for watching.